Good morning, everyone. This is Julie Foster Hagan. We're going to give it another couple of minutes before we get started. We did have some people email needing to get the registration link to be able to register. So we're going to give it a few minutes to make sure that folks are able to register and get in, and we'll get started at, so it's 10:02 now. We'll get started at about 10:05. Thank you. All right, good morning, everyone. We're going to go ahead and get started. Good morning, and my name is Julie Foster Hagan. I'm the Assistant Secretary for the Office for Citizens with Developmental Disabilities. And thank you so much for joining us today so that we can share with you guys some information about our planned changes to our home and community-based waiver services after the end of the public health emergency. So just a little housekeeping first. Due to the large number of participants that we have on the call, we're not going to be able to open the lines for people to share or add to the discussion. However, at the end, we will go through questions and answers. So on your computer, you should see a bar at the bottom, and there is a Q, it's called Q&A. So if you have formal questions or comments that you would like for us to read into the record, please enter them into the Q&A box. There's also a chat feature, and I see several folks have already entered in the chat. We will not read questions and answers from the chat. I find during these presentations, a lot of times folks like to talk amongst each other, so you can use the chat to informally communicate with each other. But if you want us to address questions or comments directly, please use that Q&A box. And when I get to the end of our presentation, I will go through and answer the questions that I'm able. Some of them I may need to take away and have communication with my staff to be able to answer, but I'll answer the ones that I'm able to. We will be recording this presentation, so please note that the presentation is being recorded. We will have the recording as well as this PowerPoint and the questions to our Q&A posted on our OCDD website. It oftentimes takes us a couple of days, but we will have all of the, again, the recording, the PowerPoint presentation, and the questions and answers on our OCDD website. If you would like to send in any questions or comments after this webinar, or if you're watching the recorded version and don't have an opportunity to enter into the Q&A, you can send us an email to ocddinfo@la.gov, and we will include that in the Q&A responses that we put out on the website as well. All right, so before we jump into the plan for after the public health emergency, I do just want to share a little bit of information about home and community-based services. For many of you, this may be information that you already know, but I just want us to be able to kind of start with an understanding of some general information about home and community-based services in general. So first off, I want folks to know that there are a lot of different ways. Most everyone is likely aware that we have 4 home and community-based waiver services under the Office for Citizens with Developmental Disabilities. That's our Children's Choice Waiver, our Supports Waiver, the Residential Options Waiver, and the New Opportunities Waiver. And there are a lot of different places that there are rules and regulations related to how our home and community-based waivers operate. One of those ways, one of the primary place that we have rules and regulations is in our 1915C Home and Community-Based Waiver Application or Amendment. So CMS there's lots of different ways that states can choose to offer waiver services. Most are, a lot of times when we have personal care services, those are traditionally through a 1915C waiver. Again, there's different types of authorities, but for our 4 waivers, we follow the 1915C process for our waivers and that's through CMS. We also have rules and regulations in the Louisiana Administrative Code, which also includes information about our state plan services. Those are the rules. Those are the rules pertaining to Louisiana, and we'll talk a little bit more about this. And then finally, we have information that really is the details of how our waivers operate in our OCDD waiver manual. So a little bit more about the 1915C waiver application. So again, the CMS has different ways that states can ask for waivers. The 1915C is the current method that we use for our 4 waivers. And what we have to do is we have to submit anytime that you have a waiver that you want to do in your state. you have to complete what's called a waiver application. And CMS has a form that we have to fill out that goes into a portal. And in the application, there are several different things that we are required to include. And there are several requirements that CMS has when you use a 1915C waiver. There is something called a 1915C technical guide. So for anyone who's interested, you can go to the CMS website and find, it's a very lengthy document, but there is a technical guide that includes all of the rules and regulations that we have to follow when we submit a waiver application. And again, it does have rules, services. We have to tell how we develop our rates, and then there are other requirements. A waiver, we must submit a waiver anytime we have a new waiver, which our most recent one was our residential options waiver, but then we also have to redo it every 5 years. So most recently, our new opportunities waiver is expiring. The 5 years is up in January. And so we recently did updates to our new opportunities waiver and submitted it to CMS, and that was a part of that 5-year renewal process. So they normally take that normally takes us between 5 to 9 months to be able to complete, and that is from that is the renewal actually takes 5 to 9 months. A new waiver application would take longer. I think the residential options waiver took us more like 2 or 3 years to develop because there's a lot of new development. But a renewal typically takes 5 to 9 months because we have to do a review of the entire waiver and make any major updates at that time. And then it takes CMS time to review and approve. In between that renewal period, so in between those 5 years, we can make changes to what we have outlined in our waiver, and we call those a waiver amendment. And the waiver amendment can be submitted for those changes again in between the renewal period. That typically takes us 3 to 6 months. So that 3 to 6 months includes time that we need to get stakeholder feedback, look at what we want to develop, look at what the regulations are to make sure that what we're submitting falls within the regulations. And then we always post for public comment. That's a requirement from CMS. And then CMS typically has 90 days to review and approve our waiver amendment. That does get a little confusing sometimes because when we submit it, they have 90 days. They call it starting a clock. So CMS has 90 days. However, if they have questions about what we're proposing or what we want to do, CMS can take it off the clock, which means that they pull the waiver, that we have to respond to written questions for them, and then they kind of start a clock over. But they can kind of come on and off the clock if they have questions about what we're doing. Again, most recent example of that would be when we added the complex care to the now for the home and community-based waivers. We did develop a plan, and CMS had a lot of questions about it, and we had to kind of continue to go back to the drawing board. And that waiver amendment ended up taking us almost 2 years instead of the 3 to 6 months. And again, that was because CMS just had questions, and we had to make modifications to what we were doing to be able to get CMS approval. And then you'll hear us talk a lot today about Appendix K requests. So during an emergency, there must be a declared emergency. So during an emergency, CMS allows states to do an Appendix K request. And what that means is that states are allowed to make temporary changes to the waiver, and we're allowed to do things that are not allowable during the regular times or as part of the regular CMS regulations. And we're able to do that because we are in the mode of emergency response, and they understand that some of the typical regulations that are in place, we might need to do different, we might need to go work outside of those parameters in order to keep people healthy and safe. Because we use it during emergency, it's a much shorter turnaround time, and the documentation itself is much shorter as well. We can normally get an Appendix K approved anywhere from 1 week to 60 days because, again, CMS is doing that. We'll do that much faster. The waiver applications and the waiver amendments, we always, as I mentioned earlier, must submit those for public comment so people have an opportunity to share any comments or questions about what we're proposing to do, which will happen for these waiver amendments we're talking about today. Folks will have an opportunity, and CMS requires us to send a summary of the feedback that we received and include that when we submit our waiver application. Because an Appendix K is temporary and related to an emergency, a public health emergency, those do not require public comment. We are able to enact those. But CMS must approve the application, the amendment, and the Appendix K. So all of the things that we propose are still subject to review and approval by CMS. And if they are not approved by CMS, then what happens is that we lose the federal funds that are associated with the service. So typically for our home and community-based waivers, the state puts up a portion, and then the federal government puts up a larger portion that we call federal match dollars. And that's normally about 63 to 67% of the total cost. So there's a, we really need to make sure that we're following CMS rules and regulations and guidelines, or again, we're at risk of losing that federal participation. In terms of rulemaking and state plan, I mentioned that as another place that you see regulations related to our waivers. There are state statutes that direct agencies to engage in rulemaking process in order to implement new state and federal laws and to update rules that are in place. Where you find these rules is that they are published in what's called the Louisiana Register, and they must be in accordance with the Administrative Procedure Act. When we do make changes to our rules, and again, we have some information about our rules and regulations and processes in our amendment. We then have some that go into rulemaking, and if we want to make changes to those rules that pertain to the Louisiana Administrative Code, those also go through a public comment period. Those, again, are through the Louisiana Register. If you are interested in receiving those, you can go to the Louisiana Register website, and they will send you email notification when there are rules that come out. We also have legislative involvement in our rules, again, because it's related to the administrative code. So we have rules, but we have a rule associated with each one of our 4 OCDD waivers. And there are also other rules that are outside of our waiver, but they pertain to our home and community-based waiver services. And so some of those things might be in state plan or other rules outside of that. So there's lots of different places that we have these regulations. And again, it takes 4 to 6 months if we want to update those to come up with new rules or to complete updates. I mentioned this already. Some activities that impact our waiver services are part of Medicaid state plan. The Medicaid state plan, though, unlike the rule, just the rules, our other rules do not require CMS approval. Medicaid state plan services that are part of the rule do require CMS approval. And if you want to make temporary changes during an emergency to state plan services, that happens through what's called an 1135 request. So for us in waiver services, that's Appendix K is the route we use to make temporary changes. In state plan services, the 1135 is what you use to be able to make changes to state plan services during the emergency period. And again, CMS must approve them. And then the last place that I want to talk about where we have, information about our home and community-based waivers is in our waiver manual. You actually can find our waiver manuals online as well. And it's really where we have the most detailed information about operationalizing our waiver. It's where we have more detail about the requirements for the services in each one of the providers groups that we have. We do undergo an LDH internal review process. So when we update our waiver manuals, there's not a requirement for public comment in the way that our rules and our waiver application have a requirement for public comment. However, we do work with our stakeholders for feedback prior to making changes. And then we also conduct training after the changes that are made. So while CMS approval is not required for our waiver manuals, our manuals still must not contradict any of the approved information that we have in application or rule. So it requires that we operationalize things within the parameters that CMS sets forth for us. Typically, because we don't have to have the public comment period or CMS approval, the process for updating our manuals is shorter, and we can usually do that within 2 to 3 months. And that includes having a period of time for input from stakeholders about the changes, making the changes, and then doing any needed training that might need to occur because of those changes. Typically, and also when we do have our temporary situations, like we have now under our Appendix K and 1135, we don't update our manuals to reflect those temporary changes or emergency situations. We would handle communication related to changes that would potentially impact our manual just through memos or through other forms of communication with the individuals that are impacted, providers or family members. So that gives you a little bit of background. And so now I'm going to shift and talk to you about the waiver exceptions that we've had in place during the COVID-19 public health emergency. So just to give you guys an overview, we have had Appendix K changes, we've had rule changes, and we have had 1135, so state plan changes in place since February of 2020 associated with COVID-19. I can't say this for absolutely sure, but for at least in the last, in current history, we've not had a COVID, a public health emergency that lasted beyond a year. Normally when a public health emergency is called, things we're used to here in Louisiana are public health emergencies related to storms, hurricanes, flooding, occasionally winter weather, but not quite as often. You know, California often has public health emergencies related to wildfires. There have been other public health emergencies related to infectious diseases, but by all means, COVID was something new. So for the first time that in again recent history, CMS allowed for the public health emergency to extend beyond a year. Normally, these must end within a 12-month period. When they declare a public health emergency, because we've gone beyond that year, they can only do it for 90 days at a time. You cannot extend more than 90 days. So our current public health emergency for COVID-19 is in place until January of 2022. It can be extended and may be extended again for another 90 days, but they don't normally tell us about the extension until we get, closer to that time frame. The Biden administration has publicly said that they would inform states 60 days before the public health emergency is scheduled to end. And as of today's date, November the, whatever today's date is, November the 10th, as of November the 10th, we have not been informed that the public health emergency will end within the next 60 days. we have been trying to make sure stakeholders are aware, and we will continue to communicate things as soon as we have any more information about that, or if we were informed that there would be an end date, when the end date for the public health emergency will be. So what CMS has said is that they recognize that a lot of the exceptions we have in place for COVID, that it's going to take time for families to plan. It's going to take time to do things differently, and we need to be able to build that in. We can't just have an end to it without some time frame built in for planning purposes. And so what CMS did was they allowed states to ask for an exception to say, we would like to have all of our Appendix K exceptions stay in place until 6 months after the end of the public health emergency, whenever that may be. Louisiana did send a request in to continue our Appendix K request for an additional 6 months, and CMS granted that, so that has been approved. So today we're going to get into the details of what will happen after the public health emergency, but I want to make sure that people understand that what we have in place, with the exceptions that we have in place now, will stay in effect through 6 months after the end of the public health emergency. And the changes, the longer term changes that we're planning to make in our waivers, won't become effective until we get past that 6 months after the public health emergency. In most cases, there may be a rare circumstances, and I'll talk about that when we go through the presentation. But for the most part, most everything that we're talking about will continue in place until 6 months after the public health emergency ends. And other than, again, there's a very few things, and those things are because while CMS has said that the Appendix K, remember that's the changes for the waiver, can go in effect for 6 months, the changes for in the 1135, so the changes that are in place in our state plan services, they have to end when the public health emergency ends. So that'll only give us a 60-day window of time for anything that's included in our 1135. And again, so what we've been working with stakeholders on now are changes that you will see that will be made to our waivers so that we have them clearly in place well before we get to that 6 months after the end of the public health emergency, so that people have an appropriate amount of time. Some of these changes, will affect the plan of care and affect, conversations that we need to plan for, and we want to make sure that people know well ahead of time what the plans will be after the public health emergency. So there were 3 primary areas that when we met with stakeholders, some of you may have been involved in listening sessions that we had several months ago. During the legislative session, there was a lot of attention paid to the exceptions that were in place. And there were 3 primary areas where we heard from stakeholders that they wanted to have some conversation about continuing things even after the end of the public health emergency. And those 3 areas were family members serving as paid caregivers, the ability for staff to work over 16 hours a day, which you'll hear us call the 16-hour rule, and some consideration related to virtual visits. And so we heard from stakeholders, and when it came to these 3 things, we had different stakeholder groups who maybe had a different idea about what should be continued, what shouldn't be continued, how do we make sure that we're continuing to ensure health and safety, but still allow flexibilities for folks. And so what we did is we established focus groups, and we established 3 focus groups. And the goal of our focus groups were for us to provide relevant information and research on the topic for background information, So again, we wanted to share with the groups if there were regulations, what are those regulations? What are the CMS mandates? Remember, I told you CMS allows us to do some things on a temporary basis during the public health emergency, but then there's other regulations that we must follow. So we took a look at those. We took a look at background information, and then we had a brainstorming. So we will brainstorm among the work group members so that we could hear the different points of view and have just a really engaging discussion about that particular topic. And then we worked to come to a shared consensus, which we were able to do in most cases. I don't know that the consensus that everyone was thrilled. There was some give that had to do, and there are some things, and again, I'll share that with you, that legally we are not able to do to allow for certain flexibilities. But we did have a robust discussion and come to as much of a consensus on a plan to move forward as we were able to get to. The way that we selected the participants for our focus groups is we sent a communication out through all of the different ways that we normally communicate with folks, and we tried to make sure folks were aware, and we had a registration period. We did limit our focus groups to 26 people, and that was so that we could make sure that we didn't have too many people, because we really wanted to engage in a robust discussion. We did do a poll during our focus groups, and some of the feedback we received is that 26 may have actually been too big, that we might want to make groups a little bit smaller for future, because we do plan to continue to use this focus groups. Overwhelmingly, people felt like operating a group in this manner, where we have all of our stakeholders at the table together to really vet an issue, with I think we had 100% on that response. So folks really liked having everybody together so that we could all engage in the conversation. We did have over 200 people who registered for our focus groups, and to make sure that we had diversity in our focus groups, we first looked at the participant type. So people registered either individual with an IDD, a parent or family member of a minor child with IDD, a parent or family member of an adult with IDD, a representative of an advocacy organization, private providers, support coordinators, and local governing entities. And all of our group, 3 focus groups, had multiple people from each of these areas that represented, with the exception, unfortunately, of individuals with intellectual and developmental disability. We only have one person who registered who identified themselves as an individual with an intellectual and developmental disability. They were, of course, placed on the focus group, but unfortunately, we did not have individuals who signed up. And we then, kind of looked at participant type first, and then we did a further breakdown by geographic area to make sure that we had people from rural and urban areas and different parts across the state. And we also then looked at gender and race to make sure that we were had a good diverse group of people for the focus groups. So again, before I jump into sort of our discussion, we got really great feedback on that. We will be looking for opportunities, in the upcoming year to use that format for focus groups again. In my opinion, we definitely need to make sure we're hearing from the people who are receiving services, the families who help support them, and the providers, as we look at moving forward and the plans moving forward. So we will definitely do this again. I personally thought it was much more worthwhile letting everyone hear from each other. Prior to this, I think a lot of times we just talk to providers, or just talk to advocates, or just talk to our LGEs. So having everybody together so they could jointly hear, thoughts or concerns that other people had, I think was impactful in helping us to be able to tackle some difficult conversations. And I appreciate, for those of you who are on the call now and participated in the focus groups, very much appreciate those folks who took the time out to be able to do that. So now I'm going to dive into information from our 3 focus groups. The first focus group we'll talk about is the family as paid caregiver focus group. And our key takeaways, again, from all of our stakeholders, is that there are definitely benefits to having family members be able to continue to be paid caregivers after the end of the public health emergency. We did have some family members who said that they want to just, make sure that if the family member is the paid caregiver, that there are opportunities for other non-family members to also provide services, whether that be through respite or other workers, because of the difficulty, of having to do that, of having to provide those services and be able to be a family member. Some of our provider agencies reported to us that, we are, and we do recognize here in Louisiana and nationally, there is a workforce crisis. And those people who provide those direct support services, there's not nearly enough of those people to be able to meet the needs. And we are truly in a direct support workforce crisis. That's kind of our next focus group that we'll be tackling. But and so what providers said is that having those family members be paid caregivers has really helped with that, because the family member being able to be paid and provide that service has been helpful, because there are not those non-family members who would be paid direct support workers, and the availability to recruit and retain those staff is very difficult. So having the family members be able to do that has helped ensure the health and safety of the individuals who receive services. We also had some folks on our stakeholder group, or our focus group, who felt strongly that we needed to make sure that self-determination is preserved, and that we need to make sure that the individual is choosing to have their family member be their paid caregiver. We know that a lot of times family members have the best interest at heart, but we sometimes can overprotect or try to keep our loved one with a disability so safe that we maybe don't kind of allow them to live their life maybe the way they would want to live their life. And so again, we just need to make sure that we have mechanisms to make sure that the individual themselves is choosing to have their family member be their paid caregivers. And then, as you'll see through some of the mechanisms, we also do need to make sure that there's a mechanism to monitor family members as paid caregivers. We had a lot of discussion about that monitoring needed to be in the same way that we should monitor all direct support workers, but there does need to be a mechanism. There still needs to be a mechanism for monitoring. We also had a key takeaway from our focus group that we need to make sure families understand all the requirements that surround being a direct support worker, and that help them understand that once they become a direct support worker, there's a family role that they have, but then this is a different role and a new role, and need to make sure that they understand any of the regulations or requirements so that they're not doing things that are kind of against the rules, for lack of a better way of saying that, and that there may need to be some additional information provided to families to make sure that they understand that. So that folks are aware, I'm not going to sharing with you guys all the information we shared in the focus group, because we really dived deeply into the regulations, but I do think that because this is such a hot topic item right now, I do want to make sure that at least at a high level, you guys understand some of the CMS regulations. CMS recently did a webinar that you can also find on the CMS website called Leveraging Family Members as Paid Caregivers. We can actually put the link to that on our OCDD website as well. But it is kind of a guide for states to help understand the CMS regulations when we do. So states can choose to allow family members to be paid caregivers, or states can choose not to. When states do choose to allow family members to be paid caregivers, there are certain regulations that we are required to follow. And again, those are outlined in that 1915C technical guide. And then more recently, CMS did a webinar presentation to help summarize what some things states might want to consider when allowing family to be paid caregiver, because a lot of states are dealing with just what we are here in Louisiana, where under the Appendix K, family members who may not have been able to be paid before were able to during COVID. And so there are a lot of states exploring now how to potentially expand that. So one of the things CMS says that we must do is we must differentiate between live-in caregivers, relatives and or legal guardians, and legally responsible individuals when we define caregivers. They also say that states should have we should have a state regulation that identify what each one of these groups are when we have them when they're a part of providing care. In the CMS regulation, it actually in the CMS waiver application, there's actually little boxes that we have to check. So for each service that we provide, we have to check a box that says, do you allow family members, relatives to be able to provide this service? And do you allow legally responsible individuals to provide this service? And if we check those boxes, then we also have to do these additional things. So when we allow family members to be paid caregivers, we have to specify the type of family caregivers to whom payment may be made. We have to specify which waiver services payments may be made. So for example, the primary services we looked at were the individual and family support in the now, the community living support in the row, the family support in the Children's Choice Waiver. Those are kind of those in-home services. But we also looked at monitored in-home caregiving and companion care. And you're not going to see us talk a lot about this because our focus group really kind of focused in on the individual and family support, the CLS, community living supports, and the family supports, and where those would go. But we will also continue to have allowances in our monitored in-home caregiving, and then we're also looking at companion care as well. So when I say that we have to specify which waiver services, in our waiver application, it lists the service and then it has the box. So that's where for each one of those, we have to be able to say whether there's an allowance for family members to be paid caregivers. We also have to state if there are any limitations on the amount of services that may be furnished by family caregivers. We have to show how we ensure payment is made only for services rendered. And so again, it gets a little complicated when you have family that, they have a role as your family member, and then they have a role too if they become a paid caregiver. And so we have to make sure that when they're being paid, that they're being paid for services that are happening through that paid services, and that we're not making payments when folks are doing things that they would do as part of just being a family member. We also have to show how we ensure that the services furnished are in the best interest of the individual. So we have to be able to note how we document that the family as the paid caregiver is in the best interest of the individual receiving services. And then family members who are paid caregivers must meet the established provider qualifications. What that means is that all of the requirements that you have to be a direct support worker, if you're not a family member, you must meet those as well. So we'll talk a little later. During the public health emergency, we did have some modifications for things like doing background checks and some training. But what CMS says is that's allowable during emergencies. But in normal times, if you are a paid family member, you still have to do all of the same things that someone that is a direct support worker who's not a paid family member needs to do. And so you have to meet all of the, whatever regulations we have in place for them, we also must have in place for the family as paid caregiver. And then all of those things are in effect for paid family members when we allow legally responsible individuals to also be paid caregivers. They take it a step further and say that we can only pay for the provision of extraordinary care. We had a lot of discussion in our focus group about extraordinary care, and what CMS means by this is not that the person has an extraordinary need. Well, it's not it's not really a description of the level of need. What it is that when you are a legally responsible individual, and they often use things like the spouse or the parent of a minor child. So when you are the legally responsible individual, there are things that you do that are part of ordinary care for that person. Cooking dinner, going grocery shopping, those kinds of things are things that you would do just as part of what is ordinary care for that person. And so we have to say the only time we can pay the legally responsible individual to be a paid caregiver is when we show that what they are being paid to do is outside of ordinary care, and it is extraordinary care because of the person's needs. And so we have to make sure that we include that the only time legally responsible individuals will be paid is when they are providing extraordinary care. And so the decisions, and again, I think more than any other, this one was definitely a compromise to try to address everyone's concerns. We still, and I know because I'm continuing to get some emails from some of the focus group members of things that we need to follow up on in individual situations. But again, we had to come to a compromise that got us to a place that we felt would follow the CMS regulations, continue to assure the health and safety of folks, but still have some flexibility to continue things. Again, and I want to make sure I'm clear because I think I've gotten several emails now about this. Family members that are being paid caregivers right now will be able to continue to be paid caregivers as they are right now until 6 months after the end of the public health emergency. So these decisions and stuff that I'm talking about, they do even though we're putting them in the waiver now, they do not come in effect until 6 months after the end of the public health emergency is when these changes will take effect. So the decisions that we came to from the focus group and from some follow-up on there were some legal regulatory kinds of things we had to follow up on as well. Right now, even before COVID, if you were a family member but you did not live in the home and you were not a legally responsible individual, there was no restrictions on being a paid caregiver, and we will not make any changes to that. So if you're not living in the home, and we need to make sure we add that caveat, and not a legally responsible individual, then there are no restrictions. If you are a family member that's living in the home, then you will be able, this is where CMS says you have to identify limitations. So family members living in the home will be able to provide paid services up to a maximum of 40 hours a week for each family member. Some of you may have seen in our new opportunities waiver, we attempted to address this, and the limitation that we put was 40 hours a week for all family members. This will change that to say that any family member who qualifies to be a paid caregiver can provide up to 40 hours across them. But I want to make sure that people are clear when I say up to a maximum of 40 hours. So we use the person, we go through person-centered planning. We also have resource allocation in place. And so when we talk about the family members being paid caregivers, that's outside of the discussion about the number of hours that a person needs or the hours of support that a person needs. So we say up to a maximum of 40 hours because we have a lot of people who receive home and community-based waiver services who don't need 40 hours of paid service per week. And so it may be that there's less than 40 hours that the person has in their plan. We call that their prior approved number of hours. And so when a family member does then become the direct support worker, that doesn't mean that there's automatically 40 hours of paid care that person needs. That's still, again, based on their person-centered plan. So again, that's why we have that kind of the caveat there of up to. And then, you know, as I mentioned earlier, when I went through the regulations, we will also need something in our waiver application that indicates that paid family members must meet the same qualifications as other direct support workers, including the mandatory training that we have in place and passing a background check. We will also need to make sure that there's an understanding that paid family members must follow the same documentation requirements and work expectations as other direct support workers. So when you're a family member in the home, if there is a critical incident, then that paid family member must complete the critical incident reporting. When using the individual and family support, community living support, or family support in Children's Choice, and that's done on a unit basis, then we must use electronic visit verification. So just like direct support workers have to, you know, clock in when they're there and clock out when they're gone, that is mechanisms that we have in place to someone is physically there and that's being followed. So the family members will have to use that. When we use the monitored in-home caregiving and the companion care, there's not a payment on an individual basis. It's more like a payment per day. So we don't necessarily use electronic visit verification there. But again, when you're paid by the 15-minute increment, that is a requirement then that you complete the electronic visit verification. And we have that in place for traditional provider agencies as well as for self-directed services. So again, the family members will need to do that. Any progress notes or documentation that's in place, that's required through the, you know, that's talked about in the plan of care meeting. And then different providers or employers have different expectations related to documentation. So whether you're a family member or a non-family member, again, you have to follow the documentation and the use of those progress notes, kind of check in and check out information. So that's where some families really felt like, and you'll see some in the follow-up actions that we're going to do, that families may need a little more education to understand that. Folks also need to know that when you're being paid to provide the service, that you are being, because you're clocked in to provide that service, that is basically then your job. So you cannot be on the clock and being paid to be a paid family member at the same time that, let's say, you're doing another telework job. You can't do both at the same time. And we have had some confusion around that issue. That is in place now too, so I do want to make sure that we clarify that. If you're being paid to provide these Medicaid services, you cannot also be on the clock being paid to do another job in the same hours. That's a conflict. You can't do both at the same time. We will also include in our waiver application that paid family members will be subject to the same monitoring by either the provider agency or the employer as other direct support workers. Again, we have to be able to show that we have a level of monitoring. That means that we're going to have to be doing, you know, checks on the EVV, that making sure that payment is for services rendered. If there are, you know, quality checks that need to happen for how the services are being provided, those paid family members will be subject to, again, those same monitoring activities that are in place as what happens for the direct support workers that are not paid family members. We also will include in our waiver application when we do have family members that are serving as paid caregivers, that's going to need to be included in the person's comprehensive plan of care. So again, we'll need to start having these discussions when we know the public health emergency has ended, knowing we've got 6 months now to figure it out. We will need to be including in the plan of care if family will continue to be paid caregiver. And then we will also need to show in the plan of care why having the family member as the paid caregiver is in the best interest of the individual. Again, that is a CMS requirement that we indicate that. And a lot of the discussion we had is establishing that it's in the best interest of the individual is really a person-specific reasons that we would need to make sure were included. And then when it comes to legally responsible individuals will also be able to provide services with the same limitations and requirements that we talked about before for 40 hours a week. However, when you have a legally responsible individual in the comprehensive plan of care, not only will it have to show that it's in the best interest, but we will also need to be able to document what the extraordinary care that that legally responsible individual is providing. Again, that's a CMS requirement. And so that discussion will have to be held, and then information will need to be included that differentiates. Again, remember, this is where we have to differentiate what is what is being provided above and beyond what that legally responsible individual would do through ordinary care mechanisms. So they will need to have that discussion. I think this is likely the most kind of controversial topic or discussion that we had, but we have done follow-up with legal in a way that we currently have self-direction set up here in Louisiana. It is a conflict of interest for the employer or the authorized representative with the fiscal agent to also be the employee. So for those of you who are in self-direction, because I've gotten a lot of questions too about an authorized representative. On the documents that you complete with your fiscal agent, there is an indication of who the employer or the authorized representative is. If the person with a disability can self-direct, then they can be their own employer. If the person with a disability is not able to engage in the activities that are required for an employer, then there is an authorized representative that assists them. The name of that person is clearly stated on the forms that you fill out with your fiscal agent. So if you are listed as the employer or the person assisting to be the employer, you are basically responsible for setting the salary of the worker, doing evaluations of the performance of the worker, hiring and firing, addressing any action. And so it's a conflict for you. You cannot be responsible for doing those things and also being the person who is employed. Our LDH Legal has confirmed in the way that we have it set up now that is a conflict of interest. I've had a lot of folks reach out to me saying, well, what can I do? Again, you will have 6 months after the end of the public health emergency, and a lot of what are the options and what are things we can do, there's multiple different considerations that could be given. And so that discussion just needs to be held during the person-centered planning meetings with your support coordinator so that each individual situation can be evaluated and to determine what action needs to be taken. But again, in the way that we currently have our system set up, we're not able to have an allowance for the employer to also be the paid employee in self-direction. There are multiple things. So those are the things that we will have in our waiver application itself. There are multiple things that we need to follow up on, and this particular focus group will continue to meet after we get the waiver application in place to follow up on several different things. So one of those things that we'll follow up on is that there was discussion of needing to have more information and training for families on the system and the requirements. There was some discussion about developing an attestation form for paid family members to complete. We wanted to make sure that any forms, I noted here in different languages in Braille, but we did have some discussion about needing to have more information in different languages in Braille, but that there would be an attestation form that family members could sign indicating that they understood the system or that they were able to take additional actions if they did not. We also need to talk about training for family members, how that's done in conjunction with the other direct support workers, and if there's additional training needs. Some of the members of our focus group felt like there needed to be additional training. Some felt like the training should be a part of something similar to what the other direct support professionals go through. So we need time to kind of vet that out and make sure that we're giving people what they need, and we can set these requirements in place in our waiver manual. We don't have to give this level of detail in our waiver application per se. We also, I mentioned earlier that CMS says that states should have a rule in place that clearly identifies, in this instance, what a legally responsible individual is. And again, remember if you are a legally responsible individual, you can be a paid caregiver, but you then have to show the extraordinary care. So because that's an additional step, we need to clearly define who legally responsible individuals are and establish that in a rule. And so we will be doing that as well, so that it is very clear what the state mandate is regarding legally responsible individuals. It's very clear that it is the spouse and the child of a minor, the parent of a minor child. When you get into things like interdiction and continued tutorship for adults, it's a little clearer if there's full interdiction, but then there's all different kinds of partial interdiction and other rules. So we're going to really have to dive a little deeper into the legalities of that, so that we can clearly establish a rule so people know if they are where they fall there. And again, the legally responsible individual in this case doesn't make a statement as to what you can or can't legally do. That's defined through the power of attorney, that's defined through supported decision making, that's defined through your curatorship and what the interdiction papers say. For these purposes, the legally responsible individual, it will just be those that have an expectation to provide care. And so you would then have to show where the extraordinary care kicks in versus ordinary care. So we will be working to better define those. We will include information about that in our waiver. We will indicate that we will utilize our plan of care and our person-centered planning discussions to talk about whether it is in the best interest of the individual and whether it's extraordinary care in cases when we allow the family members to be paid caregivers. So we will have to have language in our waiver amendment that says that we will do that. However, we can put the details of what that criteria is in our manual. And so we have a little more time then to be able to vet these things to get it in our manual. So we will be defining criteria for extraordinary care so that in those plan of care meetings, it's clear what discussion needs to be held, what the criteria is for that extraordinary care, And again, we have more work to do on that. That's something that is going to take us some time to really discuss and get feedback on to plan that out. We also are going to have to develop criteria to ensure for how do you really define what is in the best interest of the individual. Folks felt that it was very important that we have a conversation initially and then annually with the participants themselves so that they can communicate to us in whatever mechanism that they use to communicate that this is what they choose, so that we can make sure that it is, again, back to the self-determination, that this is what the individual wants. We are also going to have to look at, unfortunately, there are times when the family member may be being paid and it's not in the best interest of the person, and we need to develop a process to make sure that we're able to remove that, the ability of that to happen. Our panelists on the focus group also felt it was important that people have due process if we go through that removal. So again, we'll have to develop what that process looks like. We also had some discussion that, because this applies to biological parents, foster parents, adoptive parents, and so there is a Department of Children and Family Services has a registry through Child Protection, so we'll need to make sure that there's a mechanism that we can check that registry and that we give consideration there, and again, due process there as well. So that is our family as paid caregiver. Our second focus group was related to the 16-hour rule. As I said earlier, that is for when staff work over 16 hours. Prior to COVID, we did have a restriction in place that said that individuals were not able to work over 16 hours unless it was an emergency situation. And we defined that there was an allowance that could happen 5 times in a quarter. And after that, then there was blocked payments. And so there was, providers would get a block on their payment over that 16 hours. And there was some exceptions in place. But what we did say is that because of both the direct support workforce crisis, key takeaways, key things that our stakeholders told us, because there is a direct support workforce crisis and because of COVID-19 safety precautions, not wanting people in and out regularly, there was an increased need for the direct care staff to work over the allowable 16 hours a day. We had discussion that even though the public health emergency may end, that's not going to be the end of the direct support workforce crisis, and so there's going to potentially be the need to continue to have some allowances. But we also know that when you have staff that are regularly working over 16 hours in a day, it's not an ideal situation because that worker could potentially have burnout. There is sometimes an increased risk of abuse and neglect that's tied to employee burnout. And then just from a practical perspective, when you have folks regularly working over 16 hours a day, that's an increase in the overtime cost. And when direct support workers work over the 40 hours a week, except in some very specific situations, they have to be paid time and a half. So that gets more costly as well. And so for all of those reasons, we know that it's not ideal, but there is an understanding that we sometimes need to have people work over the 16 hours to make sure that individuals have the support that they need. In terms of regulations, CMS doesn't have specific regulations in the waiver application related to the number of hours that a staff can work. We don't have to indicate anything in our waiver manual about that. We don't have anything in the waiver manual about that. We actually have things in rule and in our, we don't have anything in the waiver application. We do have things in our waiver rules as well as our waiver manuals about the 16 hours that we will need to look at changing. The Department of Labor also doesn't have specific rules. There are some interpretations of things, but there's not rules that prohibit working over 16 hours a day. The Department of Labor is who requires, though, that staff are paid the time and a half. They're used to, prior to 2015, the Department of Labor actually had an exemption in place where the direct support workers weren't required to be paid time and a half when they worked overtime hours. However, that's no longer in place, except they do have what's called a companionship exemption. So some folks still are able to get a companionship exemption, whereby they then do not have to pay the time and a half overtime. But again, that's not a process that's dictated or mandated by OCDD or LDH. That actually goes through the Department of Labor for review. Okay. So the decisions that we made related to where we will go from here for the 16-hour rule. We currently, as I said, it's currently in our rule that staff are prohibited from working over 16 hours except in an emergency situation. So a decision was made to strike that from rule. And then we would, in our waiver manual, put the following processes in place. We have here no direct support worker should be pre-scheduled. We still have a little bit of work to do on exactly what that language will be, but what we really want to show is that direct support workers on a typical regular schedule, so they should not be regularly scheduled to work more than 16 hours a day, and that they should only work over 16 hours in a 24-hour period for unplanned situations when a paid staff or natural support is not available and the person cannot be left unsupported. Again, we heard clearly from folks that typically when you had to do this, it was because either a staff person didn't show up, so they needed to work over 16 hours and not leave the person alone, and then wait until they could find another replacement or backup if possible. Sometimes they couldn't, so they had to work even longer. But the times when you need this really don't, you can't get prior approval for, because you don't know when it's going to happen. And, you know, normally it's going to be in the middle of the night or on a weekend or things like that. And so we're no longer or not going to require any type of prior approval to approve a staff working over the 16 hours in a 24-hour period. What we will do instead, you know, again, back to it's not an ideal situation, and we need to do all we can to try to help make sure, and again, it's for what's in the best interest of the person, that they're not having staff that are consistently having to work over those 16 hours. What we'll do instead is do a review, a retrospective review. So after it happens, then we will do a review and take a look at what happened. So we do, our SRI system can trigger anytime a staff works over 16 hours because of the electronic visit verification. And so what will happen now is that if a staff works over the 16 hours, then either the traditional provider or the employer in self-direction will need to review each time an instance occurs to see just to see what happened, make sure, are there any health and safety concerns for the person? Are there any potential barriers or things we need to do? Or we just, on isolated incidents, just having to use this because staff don't show up or things like that. The current process is that can happen 5 times in a quarter. So we stuck with sort of that same requirement, and what will happen is if it happens 5 times in a quarter, so if staff have to work over the 16 hours 5 times in 1 quarter, then that'll send a trigger to the support coordinator who will call a team meeting. During that team meeting, there will be discussion, you know, why are we having to do this? Is there a problem? Are there things we need to look at, or do we need to try to address? Do we need to look at the backup plan for folks, you know, and develop a plan of action to address it. And then after that, if that if in the very next quarter, the next consecutive quarter, there's another instance where you have 5 times that a staff has to work over the 16 hours, that'll then trigger a review by the local governing entities. Again, they'll look at what did the support coordinator and providers, what happened during that team discussion, what's going on, what's in place. Are there any additional actions that we need to recommend to try to help address whatever the situation is so that they're not having to use it? And again, they'll make recommendations at that level. And then if it happens again for the next consecutive quarter where they're having to have staff work over the 16 hours, then that'll bump up to our central office level. And we will, again, do the same. We'll review what happened at the team level, review any recommendations by the LGE, and make our recommendations. This is not intended to be a gotcha. We will not block any payments. As I said, prior to COVID, we were blocking payments. We won't be blocking payments. We won't be requiring prior approval. This is just a mechanism for when we're having to do this regularly, that we at least have some additional monitoring in place to see if there's any discussions or assistance or issues that need to be discussed to try to help address not needing to have staff consistently work more than 16 hours a day. And then our third focus group was related to virtual visits. And so some of the key takeaways from that discussion were that during COVID-19, virtual visits have helped to keep participants and families safe by limiting the in-person interactions. We know that's what the CDC mandates and a lot of our state mandates were. However, what a lot of folks on the work group said, and a lot of the key takeaways, are that in-person visits are often needed to make sure that we're assuring the health and safety of the participant and to be able to actually observe that the plan of care is being followed. Folks also very loudly let us know that we need to be thinking about increased use of technology across all services so that we can be more efficient, whether that's electronic signature, access to equipment so that people can use technology and can visually see things. And so there was a strong request from us to take a look at how we use technology, not just in the services I'm about to talk to you about, but kind of across the board. So we heard that loud and clear. Again, when it comes to virtual visits, there are no specific CMS regulations requiring face-to-face or in-person visits, but we do have state regulations. So in our state plan and in our health standards and licensing and certification requirements, there are processes that do require in-person visits. And again, it goes back to making sure that we are ensuring the health and safety of our waiver participants. So what were the decisions then for our virtual visits? So we looked at 3 major service areas when we looked at virtual visits. One of those is the initial certification that's done by the local governing entity when someone first begins receiving home and community-based waiver services. We talked about the supported independent living service. That is a service in our new opportunities waiver whereby people who need assistance with things like money management, paying rent, taking care of those kinds of things. It's a service that individuals can receive to help them with those kind of activities. And then thirdly, we talked about the support coordination, team meetings and visits and things like that. So where we landed, again, after discussion and feedback from everyone, is that initial certification visit that the local governing entities do, there is with the face-to-face requirement that we would continue, that we would, at the end of the public health emergency, go back to requirements that initial certification visit be done in person or face-to-face. There was also discussion that again, for people who get the supported independent living service, There is a requirement that at a minimum there be a monthly face-to-face contact for the person receiving those services. And folks felt like in the large majority of time that should return to being a face-to-face requirement because of the type of service that's being provided there. Folks did feel like we needed to have an exception process there, so we will include in our manual the ability to request an exception to the monthly face-to-face contact, and the exception request will have to include a justification for why it's needed and to demonstrate how the required service will be provided virtually. So again, depending on what the person's needs are, it'll have to clearly lay out how are you going to be able to accomplish that virtually. Did just want to note too, because some folks said, well, we have returned to some face-to-face or in-person meetings. So just wanted to clarify that there's not a prohibition on the initial certification visits or the monthly SIL visits being done face-to-face at this time. It's just that right now, under the COVID public health emergency, there is the option for virtual, for this to happen on a virtual basis. And again, you know, folks can consider that now. We just would encourage folks to look at parish positivity, the current mandates, and then what the preference of the participant and the participant's family is. But again, the plan now is that when we get to the 6 months after the end of the public health emergency, or at the end of the public health emergency, these things, because these are, so let me clarify, because these things are in rule, these are the things that will have to go back at the end of the public health emergency. These will not be able to continue 6 months after the end of the public health emergency, but reinstated because they are in our state plan and in our licensing regulations. So this is one example of something that we'll have to go back to the face-to-face requirement at the end of the public health emergency. And again, we should have 60 days notice for that. When it comes to support coordination, based on the group, again, folks felt that it was important that the first time you meet your support coordinator and the first time that you have meetings with them, that should occur in person or face-to-face, that it would be very difficult, if not impossible, to do that virtually. So all initial planning meetings and annual plan of care meetings will be conducted in person as they were prior to the public health emergency. And then you have a minimum of 1 quarterly meeting conducted in person. So the group felt like it must be that at least twice a year there is an in-person meeting with the support coordination agency. The additional meetings that are held by the support coordinator that were previously required to occur in person may be conducted virtually if specific conditions are met, and we'll talk about those in the next slide. And we will need to document that we will use virtual visits in the comprehensive plan of care. We did have a caveat here. Folks felt like it was important that there are some times when there are certain situations that it be best that we have in-person visits and not have the option of virtual, to be able to make sure it's in the best interest of the individual. So we will have a caveat that the OCDD and then LGEs who implement our own, boots on the ground waiver services for us would be able to require in-person visits if it's determined that the virtual visits are not in the best interest of the individual. In terms of the requirements for things that must be met to be able to have a virtual visit, we sort of have a kind of a flow sheet here, but all of these things, all these conditions must be met in order to be able to use the virtual meetings, the virtual visits for those other meetings. First and foremost, the individual and family need to be in agreement that a virtual interest is in the best interest of the person. And then the support coordinator needs to be in agreement that the virtual visit is in the best interest of the individual. And then the applicable provider agencies are in agreement that the virtual visit is in the best interest. We do have a caveat here that the legally responsible individual or family member living in the home is not a paid caregiver. Kind of going back to our first focus group, you know, one of the pieces we have to do is monitor. And so we will, if the family member who does live in the home or the legally responsible individual is being paid to provide that service, then one of the monitoring mechanisms is that we won't use virtual visits, but use in-person visits for the support coordination or team meetings. There also needs to be no instances of any of the following over the past 2 years. A discovery by the support coordinator or reported by the provider of an accident, incident, or injury that meets the critical incident review criteria. Lack of desired personal outcomes such as education, employment, and community engagement. Unsafe living conditions such as lack of sanitation, lack of food and supplies. A change in involvement in natural support. Medication issues or changes in behavior, medical status or appearance, weight loss or weight gain. Those are things that previously required the support coordinator to do a pop-in visit. And so we use that same criteria for if any of those things have happened in the last 2 years, then you would want to go with the in-person option and not a virtual option. And then you also, the final 2 things, there needs to be technology available to complete the visit so that you can have direct observation of the recipient and the home. So it can't just be the telephone. It would have to be, you know, the ability to actually see the physical environment and see the person when you're doing the virtual visit. And then you also have to have evidence that the requirements for the quarterly visit can be completed virtually. So there's a list of required elements the support coordinator has that they must do. So you must be able to do that to complete that virtually. We also had some follow-up activities that we needed to take related to virtual visits. As I said, folks felt it important that we really look at technology. And so there's a lot of time that signatures are required on certain documents and that are sometimes can be completed during the meeting, but sometimes can't be. And so they've asked, you know, we've asked, and we're going to be exploring utilization of the electronic signatures or email agreement for the required documents. We also are going to have to develop a process and expectations. I gave you kind of the ground rules for that we will need to include, but we're going to have to update our waiver manuals and our guidelines for support planning related to this process. And we will have to establish a process for tracking and documentation of the virtual visits. This has to do more with the support coordinator billing and considerations for things like that. How are folks notified if the LGE or OCD says that's not in the best interest? So we just need to kind of work through that process of how that will flow. And make sure that those updates are included in our manual and then communicated to everyone. And again, we'll have to identify a process to review a request for an exception to the monthly face-to-face SIL visit that I mentioned, and then that will be included in our waiver manual as well. So those are the primary 3 areas that we heard about from folks, but we do want to share with you all. There are also some other flexibilities that have been in place under our Appendix K that we will be, that we've also planned to make changes in our waiver. And again, just to clarify, we're going to be making these changes. They should be out for public comment around December, end of November, middle to end of November, or going into December, depending on the waiver. They will be out for public comment. So it will be all considerations for the exceptions and the flexibilities that have been in place. But again, even once they're approved, our Appendix K exceptions stay in place until 6 months after the end of the public health emergency. This just has in place long-term what changes will be there, so families can then begin that planning process when we hear that the public health emergency is ended. So we do have an allowance for the electronic verification for meetings and documentation. I'm sorry, these are waiver exceptions that we will continue after the public health emergency. So we will continue to have an allowance for that. During the public health emergency, we had sharing that was able to occur across 2 waivers at the same time, and we will continue to have the ability for folks to share across 2 waivers. So for example, if you have someone who's in the new opportunities waiver, someone in the residential options waiver, they will be able to share, but the person that's in the now, you bill the shared rate for the now and the person in the row through the row. So, but we will have an allowance, continue to have an allowance for people to be able to share. We have heard from folks that that's been helpful in some situations. We started monitored in-home caregiving in our residential options waiver when we had people who were in that service through an Office of Aging and Adult Services waiver, and they transitioned over to our residential options waiver. So we are, we're still making some tweaks, and we will have some additional amendments to monitored in-home caregiving, but that will continue to be a service long-term in residential options waiver and in our new opportunities waiver. We started 2 new services through our adult day center provider agencies. That was virtual day habilitation and small group activities as a service. And we've had a lot of very positive feedback at that. So we do intend to continue to have those 2 services in place. Again, long-term after the public health emergency ends, they will continue to be service options that people can choose. We do have some things that will be discontinued after the public health emergency, and we'll go through each of those. We did have an allowance for an additional 20 hours a week to the CAP Children's Choice Waiver. We added those 20 hours because individuals were not able to go to school, and so there was, potentially a need for those additional hours. We will not be able to continue that after the public health emergency, primarily because that has long-term fiscal implications, and so we would not be able to change that exception. So again, it's for individuals who are in Children's Choice and using those additional hours, that will stay in place until 6 months after the end of the public health emergency. But once we identify the public health emergency is ending, we'll need to have discussions about how that will change, and those additional 20 hours will not be able to continue beyond that. We also, when individuals were not going to day habilitation or vocational services, there was an automatic conversion of the number of hours that you were in day habilitation or vocational to in-home hours. That automatic conversion will also end 6 months after the end of the public health emergency. And again, for those people who you're not required to go back to day habilitation or vocational, but it's just that the conversion of the hours can't take place. So you would need to talk with your, support team about making longer-term changes to the comprehensive plan of care for what will then happen during the day. We had a suspension of background checks when the immediate family members became paid caregivers. Again, for reasons we talked about earlier, that the paid family members have to meet the same requirements as the direct support workers. That will go away. We also heard loud and clear from our focus group, they felt strongly that it should go away, and that if you're being paid, that you should have to go through the same background process. We did have an allowance to reduce the minimum age of the direct support worker to 16 years of age. It was previously 18 years of age, and we will go back to the requirement for a direct support worker to be 18 years of age after the end of the public health emergency. We also had things in place. So our statement of approval was allowed to suffice for the level of care determination, and the 90L was also able to remain in effect until the resolution of the pandemic. you know, these things were put in place because it's just difficult to get to the doctor and to get the visits that you need. However, we actually did try to convince CMS that long-term we should be able to use these things kind of, that your OCDD statement of approval should show that you meet level of care, but CMS has told us they will not allow that long-term, and that we have to have a separate eligibility process and a separate level of care determination process. So we will need to keep those two things separate. We did have some relaxation of the training requirements for the direct support workers during COVID. That will be discontinued again after the public health emergency. The same training requirements will be in place. We did have an ability to do hazard payments. That is still in place when you have, that's under our Appendix K, people who work with COVID positive individuals or people who are in quarantine. That's tied directly to the COVID event. And so that form of hazard payment will be discontinued after the end of the public health emergency. We also had in our Appendix K some retainer payments. So these were payments that were made to the day programs because they were under a mandated closure. And again, that's tied to the mandated closure and tied to COVID. So that will also, it's not really happening right now, but that allowance would be discontinued after the end of the public health emergency. So just to give you some next steps and projected timelines for where we'll move forward, and I've alluded to this in my discussion, but we are planning to post the waiver amendments for public comment in December and January. And then that way we will submit to CMS in December, January, February. The holidays kind of mess things up, but we plan to submit to CMS soon. Then CMS will have 90 days to either approve or, as I mentioned earlier, take it off the clock. But our goal is to make sure that we have CMS approval for all of these things by July of 2022. Again, if the public health emergency is not extended in January, these things will be in effect until June. CMS has told us they give us 60 days notice though, and we've not gotten notice. So there is some expectation that they will continue it at least one more 90-day period. But again, we do not have confirmation of that. But having these things in place by July of 2022 will clearly be in effect well before, you know, the time frame that we know about, so that we can continue planning. We will then update our rules as well. Those rules that are associated with any of the changes we talked about will be updated in January and February. Those will also be posted for public comment. And then again, the goal will be that we have those in place by July. And then finally, we typically wait and update our waiver manuals once we have CMS approval, because again, CMS sometimes asks you questions and makes you sort of change things as we go through the approval process. So we wait to update our manuals until we have CMS approval. We will update those waiver manuals and then conduct training as soon as we know that we have approval of those changes and we can take the appropriate steps for training. So just in conclusion, we are working to get all of the needed changes in place prior to the end of the public health emergency to allow participants, families, provider agencies, everyone to have ample time to prepare for the changes. They'll continue through the public health emergency, and the majority of those things that were in the Appendix K for 6 months, other than a couple that I've mentioned to you guys during the presentation. Support coordinators will work with participants and families on any needed changes to the comprehensive plan of care related, you know, to the ending of these exceptions. And we will continue to work with our focus group. We had the family as paid caregiver and virtual visits. We had follow-up things to do. So we're going to continue to engage our focus groups on those follow-up items. And again, if you have any other questions, I'll go see if I can answer some of in the Q&A now. But if you have any questions, you can send questions or comments for consideration to ocddinfo@la.gov. All right, so let's see if my eyes are working. So the first question I see here, are there any waiver services that would be affected by the 1135 state plan services once the PHE ends? That is specific to the criminal background checks that I mentioned. The others would be, the other services are not impacted and would be able to continue until the 6 months after the end of the public health emergency. Can we please get the slideshow emailed to us? I would like to share with DD Director who is unable to attend. Thanks. I'm assuming that it will be on our OCDD website. We're shooting to have that on there by Friday. And so folks will be able to get the presentation there. But we can also send to all of the local governing entities as well. What about special consideration for religious, cultural, and language needs of individuals receiving the services? And Karada, I see that's from you. I'm not sure that I understand the question, but that's something we can definitely continue to discuss in the follow-up focus group, because we do need to give that special consideration as we're looking at any of the planning. That should always be a part of person-centered planning, and when we're making, identifying things that should be discussed. There was discussion of needing to have that discussion in the best interest of the individuals. That plays into that. So part of what we discussed in our focus group is that there are individuals who receive services who may have cultural differences that make it difficult for a direct support worker to be able to provide services and still understand and be able to follow those cultural ideas if they're different than what happens outside of that culture. And so that would be part of the consideration of what would be in the best interest of the individual for the family member and or the legally responsible individual to be paid caregivers. So that by all means would be part of the discussion as we further vet out the criteria for what's in the best interest of the person to be able to have the family members provide those services. That's absolutely one of the criteria that we discussed that would be included. We have another question, comment regarding extraordinary care. I believe cooking, preparing meals, and other support for adults with IDD would be extraordinary care because the person with IDD would typically be living on their own and doing their own meal preparation. So we need to be careful of what we categorize as ordinary care versus extraordinary care when adults with IDD are involved. So I agree, and that's why, part of the discussion we had for legally responsible individuals is that if there's a legal responsibility to assist that person with certain things. And that is where it gets difficult when it comes to adults. And that is why we need to further define legally responsible individuals. There was, just to be clear, in the focus group, folks wanted to make sure if we said somebody was or was not a legally responsible individual, again, that doesn't change what you're responsible for with curatorship or whatnot. Legally responsible individual means that you have an obligation, a legal obligation, to provide certain services. So I agree that there may be times when you're talking about adults that then doesn't meet the criteria, but that's why we need to very carefully define legally responsible individuals, because that, in this instance, that means that there is an implication that you're responsible for providing some ordinary level of care, whether that person be a child or an adult. So we'll continue to work through that. The next question, what if a waiver recipient lives on his own? separate from his or her family members, and workers are not available. Because of the lack of available DSW, the recipient needs to move into his or her parent's home in order to receive the care needed. Can the family members, not legally responsible individuals, be paid while the recipient is living with them? Yes, they can. Again, up to 40 hours a week. And as long as the family members meet the provider qualifications, it's included in the individual's plan of care, and it addresses that it is in the best interest of the individual. The other thing I neglected to say that folks asked is that, you know, we have the limit of 40 hours per week per family member up to the maximum number of hours the person has in their approved plan. That we have some exception so that if there's direct support workers are not available, that we have some exception process. So we will also, that's another follow-up takeaway that we will be looking at, is what that follow-up is. The next question, can a family request that the worker is fully vaccinated for COVID-19, clear negative COVID-19 testing, negative hepatitis B and negative TB test? Yes, they can request that. There's not a mandate. Well, there's new mandates that are coming out now, but that we're working through, and I'm expecting folks should see additional guidance come out soon related to that. But there's nothing now that prohibits a family member from asking those things. The next question, if I am the authorized representative of my adult child and he is not deemed incompetent by the court, can he have self-directed employer and set his family workers' pay? I'm hesitant to answer that question. There's not, that really needs to be discussed as part of the person's, you know, plan of care. Part of what we do when someone goes into self-direction is talk about what support they might need to do that, make sure there's an understanding of the roles and responsibilities. So that would be one, that's a situation that's a little too specific, and the answer to that really would just depend. The next question, anything saying that these hours have to be during the week and not weekend? Parents are getting misinformation about when to use these hours. So there is, in the comprehensive plan of care, you normally have the discussion of the number of hours, and there's a typical weekly schedule. There is flexibility there in the typical weekly schedule, but the plan of care should discuss what are the paid support needs of the person. We have many people that have natural supports or support, you know, they don't need to have paid supports 24 hours a day. And so the comprehensive plan of care and that assessment process helps to define what those support needs are and when you need them, and that's what goes into the typical weekly schedule. So there's not any requirement that be done during the week, during the weekend, during after hours. It's really a part of the person-centered planning discussion about what the person needs, and then it goes into the typical weekly schedule. So it should follow that typical weekly schedule and the number of hours that are approved to be paid hours. The next question, during discussion on the family as paid caregiver work group discussion indicated that in-person visits should be conducted in situations where family was paid caregiver and as an added protection for health and safety and to preserve self-determination. Is that going to be part of the new provisions? Yes, in the virtual visit section, I mentioned that if you have a family member as a paid caregiver, then there will not be an option for the virtual visits. Those will all be required as in person, and that was a result of the family as paid caregiver discussion. Let's see, please ensure that health standards required quarterly monitoring and initial and annual on-site monitoring of staff is addressed. Okay, we'll take that back. Regarding virtual visits, I don't understand requiring more restrictions for a paid family member versus a paid non-family member, as an individual with IDD can be taken advantage of or neglected by a non-family member, especially if family members are non-existent. So the same requirements for paid family members should apply to paid non-family members. If more in-person visits are deemed necessary for a paid family member, then the same in-person visits should apply to the paid non-family member. There is no data to substantiate family members are more likely to take advantage of an individual with an IDD than a non-family member. You know, I understand that, and the part of the I think collaboration was that this would be something that would just be an additional in place. So what that means is that the 2 virtual visits a year, instead of being able to be virtual, would be in person. And again, that was an extra precaution that was discussed to be put in place. Please clarify, we are a family that has self-direction. If we can no longer be both employer and employee, can a spouse become the employer? If so, I will then, as the employee, be limited to 40 hours a week. We are approved for 83 hours weekly. Again, that's a specific family situation. Please do talk to your support coordinator. We're trying to make sure folks are aware of these changes so that they have time to really vet. There's lots of different options and things that can happen, and that's really best discussed with your support coordinator, who can elevate questions to the local governing entity, who can elevate questions to our central office. If we need to be able to be clear about what can or can't happen in an individual situation, please do escalate those. But we're encouraging folks to talk about their individual situation through their support planning process. We are getting close to time, so I'll have to take a couple of more. Will all changes, limitations, and regulations apply to both providers and self-directed services alike? Yes, other than the caveat of the employer-employee relationship in self-direction, all of the rules and regulations are the same with both traditional providers and in self-direction. The next question, if licensing requires support coordination to complete quarterly face-to-face meetings currently, does that mean the support coordinator must go back into the home once PHE ends and not 6 months later? Right now it does, unless we can get these regulations and changes in place. So we will we'll take that as a takeaway to make sure folks understand if that is able to happen 6 months after or at the end of the public health emergency. There's a request to send a copy of the presentation or post on the LDH website. That will be posted on the OCDD website. 2 final questions. Will a consideration be in place for the individuals that do not have access to VSWs and simultaneously do not have other family members to be a caregiver besides the parent? Yes, that's the exception process that we talked about, and we need to lay out the criteria and the process for that, and that will be part of our follow-up ongoing discussion. And then finally, if a patient is approved in the plan of care for 70 hours a week, can the paid family members be paid for 70 hours or only the 40 hours? So the limitation is 40 hours per family member. So it depends on how many family members you would have that would be able to do the 70 hours. And again, to the previous question, there will be an exception process if there are no direct support staff available, or if there are, cultural reasons or other considerations that need to be given. Maybe the person uses American Sign Language. So those are the criteria that we'll be developing for the exception process. But we would need to be able to show why that family needed to work beyond the 40 hours per person. So thank you all so very much for participating in our presentation today. Again, it's being recorded. The webinar will be placed on our OCDD website. The PowerPoint presentation that I shared will be posted on our OCDD website. If you have additional questions or concerns, please do send them to ocddinfo@la.gov. And we're going to also try to put together, make sure we have responses to questions that we receive and considerations for comments. So again, thank you very much for your participation today. And again, a special thank you to those who both registered for and participated in our focus groups. It was very impactful and meaningful. And we will be looking again for opportunities to continue to do that. So thank you very much, and I hope you all have a great, wonderful rest of your day. Bye-bye.